Ma'am.
Nishant is having the updated CV, madam.
Fine.
We are streaming online. Yes, Nishant.
Okay. Yes. Good evening, participants and delegates. I welcome you on our platform Shield Connect. And today, it is a very interesting topic, which is linked with COVID situation. And we have a very special speaker from Bangalore. So the today topic is approaches to improve female fertility and COVID challenges. And today with us, speaker will be Dr. Rekha Ranjendra Kumar. So before we start related to webinar, let me give a little bit idea about our page Shield Connect. So let me share the screen. So when you go to the shieldconnect.in, you can find our page where you can see various sections. The first section is the blog section where you can find various blog written related to different topics. Like right now we have curcumin in COVID-19, then black fungus, myoinositol, various topics you will find. Then there is second section that is a webinar section where you can find upcoming webinars which are linked with Shield Connect and who is going to host and when it will be started. Then there is the awareness page where you can find three different pages: immune booster, PCOS awareness page, and recently we have added COVID-19 update page. So you can see PCOS awareness page where you can find various doctors have speaked on the PCOS topic in various languages like Tamil, Hindi, Telugu, Malayalam. Then we have a COVID-19 page where you can find all the topics related to COVID-19. Then we have one more special page where you can find day related pages like for GDM, we have a GDM page. So you can find various videos related to GDM.
8,500 received on phone pay.
So this is the page of Shield Connect. And now let me introduce for our speaker today, Dr. Rekha Rajendra Kumar. So ma'am has done MBBS, ma'am is MD, DNB, FICOG, FICMCH, PGD, MLE, and Fellow Reproductive Medicine. Currently, ma'am is Medical Director in Miracle IVF Hospital and Chandan Hospital in Bangalore. Ma'am have received various awards and achievements. Ma'am held various positions like ma'am practicing gynecologist for past 30 years. Ma'am is honorary secretary in BSOG since 2020. And ma'am is also South Zone coordinator in Foxy Infertility Committee. Ma'am is also chairperson in Infertility and ART Committee in KSOGA 2022-2022. Ma'am has also done the peer review for various journals. Then ma'am recently joined as a joint organizing the secretary of Abhigyan in 2021. Foxy Figo, SAFOG, and BSOG International Conference. Ma'am has also published various papers like one case report, 9 original articles, one poster presentation in ASHRAE conference in 2021. Ma'am has also given more than 60 radio and television talks and 30 newspaper articles. Ma'am, I welcome you on our platform Shield Connect. And participants, if you have any query, please post your queries in the comment section. So at the end, we can have a Q&A session with ma'am. Ma'am, we are very pleased to have you on this platform.
Yeah. Thank you, Mr. Nishan. And thank you, Shield Pharma. Can I start my presentation? Can I start sharing my screen?
Yes,
Am I
ma'am.
audible first of all?
Yes, ma'am.
You can see me, right?
Yes, ma'am.
Fine. Okay. Let me proceed. Just a second. Yeah. Is that fine?
Yes, ma'am.
Okay, fine. Let me proceed. Okay. Thank you, Shield Pharma, for this opportunity. Without much ado, let me just proceed with my presentation. The topic I'm going to speak today is, I feel, is quite relevant. It is a topic which has two components here. What are those? One is approaches to improve the female fertility. That is, need not be the COVID time, even otherwise. Like any obstetrician or gynecologist is the first doctor any female approaches when she does not get pregnant. When she has fertility issues, say married for 1 year or 2 years, she has some fertility issues, she will approach a female doctor. So it is the duty of the female doctor to know so many things by history or examination and find out what the problem is, and at their level itself they can solve so many problems, and the woman need not approach a specialist or an IVF specialist, fortunately, if the problem is solved at that stage. What I want to say is the gynecologist or the primary physician can solve many of the problems, and these are the approaches how they can improve. So this is one part of my talk. The second part of my talk would be the COVID challenges. What happens? What are the COVID challenges that doctor and that patient will face during this journey of improving female fertility? Okay, so let me proceed. So now this is just a basic physiology slide. All of us know this just captures all the things put together in one slide. What are the requirements for conception? It's just common sense. All of us know, but just I wanted to put this slide in the very beginning. So it's a healthy egg. Presence of egg is not enough. The number of eggs are not enough. It is the healthy egg that is required. And of course, its male counterpart, that is the healthy sperm. The unblocked and healthy fallopian tubes. What do I mean by this? I mean by this that tubes may be patent. The tubes may be unblocked. Tubes may look quite fine in our HSG report, but they should be healthy also. What does it mean? Tubes unblocked is equal to not healthy always. The ciliary motility inside the tube may not be that good. The tubes may not be fine, in the sense the mesothelium of the tube may not be good. There may be circulations in the tube. The dye may pass, but the tubes are not healthy because of the circulations, dilated tubes, hydrosalpinx, the femoral additions, and whatnot. So there may be so many problems even in the fallopian tube, and they are quite unhealthy even if they are patent, and believe me there. So healthy uterus and uterine cavities, not only the uterus, that is the serosa of the uterus, the musculature of the uterus or the endometrium are not the only things. We also need a healthy uterine cavity. I'm going to enumerate on all these aspects in my future lights. So the next is the male counterpart, that is ability of the sperm to penetrate and fertilize the egg. The sperm has to penetrate the zona pellucida from its acrosomal reaction, that is in the cap of the sperm, that is in the head part of the sperm. That is not the only thing. The motility of the sperm should be fine because of the presence of the powerhouse or the mitochondria in the body of the sperm. So ultimately the sperm also should be healthy to cause pregnancy. Ultimately, what happens when the sperm is fine, the egg is firm, the union causes the embryo, and the embryo should be healthy. Okay, does the matter end there? No, not at all. This is just halfway through. Embryo is formed, but later on, what is necessary? It is the understanding between the seed and the soil. That is, the embryo you consider as the seed, and the endometrium you consider as soil. So the crosstalk between the embryo and the endometrium should be fine. One should be very cordial, one should be very harmonious with another one, and all these things, if everything is in place, that culminates in healthy pregnancy. So if there is any problem in the whole journey of whatever I have explained so far, the pregnancy will not happen and the woman will come to you with history of infertility. Now, all of us speak about words like infertility, primary, secondary infertility, etc. What do they mean? In very, very simple terms, in patient language, infertility is equal to she is not able to conceive. It is failure to conceive after 1 full year of unprotected sexual contact. Again, the history taking is very, very important here, because the woman or her male counterpart think that it may not be necessary to explain to the doctor that they were using something, either barrier contraception or oral contraceptive. She will not tell us. She will just tell that we are married for 2 years. Out of the 2 years, 3/4 of the term, they may be using some contraception. So it is 1 full year of unprotected. That means not using any kind of contraception, and that is what is called as infertility. Now, under this broad group of infertility, we have two important things, and what are they? Primary and secondary. What does primary infertility mean? It simply means that the woman has never been fortunate or never had the opportunity of getting pregnant any time in her life, in spite of having regular, frequent, unprotected sexual contact. She has well covered her ovulation period. She has given enough opportunity for her body to get pregnant, and in spite of that, she has never conceived. That is what is primary. Secondary means it's little bit different. Woman has had at least one pregnancy. You need not know the fate of that pregnancy. What happened? Did it culminate in a good baby? Did it culminate in abortion? What happened? That is another matter. But she once had the opportunity, once or more in her life, to get pregnant, and after that she is not able to conceive. So that is secondary infertility. Now, when should we start the treatment? Obstetrician gynecologist practice includes probably 50% as the obstetrics, that is the woman coming with pregnancy. Another 50% probably nowadays the infertility rate is rising so much, so I'm putting it as 50%. The other half of the practice is women walking with a big fat file in their hand, which carries all the reports that is done under the sun, saying that she's infertile, and to get pregnant she has come to you. So when the woman comes to your clinic, what are the things you should be bothered about? What are the things that should run across in your mind is, just because she's come to you, that is not all. 1 year of married life, not used contraception, fine, sab theek hai. Lekin what to do next? What to do next are the things that should cross your mind are: one, age of the couple, especially the woman. Previously we were saying age of the woman is enough, and male say even if it is 50, 55 chalta hai. No, it's not like that. Nowadays, say the past 2 years, that perception is different. Of course, the age of the woman is more important. The ovaries go into senescence much earlier compared to the male factor. If the woman crosses 35, the chances of pregnancy is very less. But nowadays, the to say is that even male age is quite important, because the DNA fragmentation index in the sperm increases much more when the male partner crosses the age of 50. So age of the couple is quite important. Second thing is duration of the marriage. How long has she been married? Duration of the effective married life. I need not stress on this fact again and again, because I have already mentioned. It just means that how long she's been trying to get pregnant, that is without using any kind of contraception. That is all effective married life means. We are also supposed to ask the pre-existing fertility factors. Had you been to another doctor before? Do you have PCOS? Are you having regular menstrual cycles? Because certain things will tell us that whether she is anovulating, whether she has endometriosis, did she have any surgery on the ovary, obesity, so many factors, so on and so forth. We will talk about those things in future. Okay, this is just one slide putting all things together, that is the age and reproduction. I mean to say the female age here. At the age of 25 of the woman, the clinical pregnancy rate is 50% at 6 months. Look at that. The clinical pregnancy rate is 50% at 6 months. That's quite good. And at the age of 1 full year of married life, it increases to 85%. And by 2 years, only 10% of the women are left with no pregnancy. That means 90% automatically conceive if they take care of their fertility issues, in the sense, one, not using contraception, second, covering the ovulation period. So 90% of them conceive on their own. So we have to tackle only those women, remaining 10%. Look at this graph now. The black line says that it is the likelihood of getting pregnant, and compare this with the age that is put in the x-axis. The y-axis says the chance of fertility is 80% when the woman is at the young age of 20 to 24. So the chances of getting pregnant, that's why I have put at the age of 25 in the left side. So when she is around 24, 25, the chance of getting pregnant is much more, and it just drops at the age of 40 to 44. Probably I can put it little more to the left, that is around the crossing line, probably would be at the age of 35 to 39. It just nosedives. What I want to say is the chance of getting pregnant becomes so low. And look at that, at the age of 45 to 49, she has only 5%. Probably spontaneous pregnancy is an anecdotal case at the age when the woman reaches the age of 45 to 49, around 45 I can say. When the woman is perimenopausal at the age of 50, you will not have any chance under the sun getting pregnant. She getting pregnant. Now the light blue line says that it is exactly opposite, the mirror image of that. What does it mean? It says that at the age of 20 to 24, the likelihood of infertility, I can also extrapolate in the sense the chances of abortion are much less when the woman is at the age of 20 to 24. When she comes to the third decade of her life, it gradually starts increasing, and that becomes skyrocketing once she is around 40, 45, and the chances of infertility is much more when she is around 45. So this is a very important slide. This should cross our mind when the woman comes to the clinic. The first question I would ask any patient is, what is your age? Because all these things are important for me. Now, what are the things in the history taking? What are the things we are supposed to ask her? Age, already mentioned, I cannot emphasize anymore. Effective marriage life, equally important. Whether it's a first marriage, maybe a little embarrassing to ask, but yes, it is very necessary, because the woman does not know the marriage, especially now. Woman walks to the clinic at around age of 34, 35, and not only that, you can also get another information whether she got married from the got pregnant from the first marriage. If that is the case, you know that she is fertile, and you can also think that probably the male is at fault. Second question would be contraception. Already told, any kind of contraception, maybe barrier. Sometimes you may be surprised even that the woman has silently got a copper inserted inside her uterus. Who knows? So this all comes in the examination. I will tell that in my further slides. But anyway, so history of contraception is equally important. Previous obstetric status, as I was already mentioning about the primary and secondary infertility, if she already has a child, we are much comfortable. We are much more happier because she already has. A bird in hand is worth two in a bush, isn't it? So the occupation, stress, very, very important. The stress causes the adrenaline rush. It causes all kind of problems. Even the hormonal secretion from the body has a direct bearing on this. The thermal injury in male, I'm not talking about the male here because the topic is totally on female fertility, but the male factor, male is equal to a male exposed to thermal injuries has a great impact on the sperm factors. But even woman, thermal injury can cause increased production of ROS, also called as a reactive oxidative species, and these are very injurious to the body, and that can again cause either infertility or recurrent implantation failure. So working in the factories like the garment factories, aniline dyes, and the timings, this is also equally important because they should have enough time to cover the ovulation period to maintain the enough sexual contact. History of coital frequency, very, very important. You can simply tell the woman that your cycle, if regular, divide into three important portions. That is the first 10 days, middle, and the last 10 days. Middle 10 days is the time you have to cover because that is the time ovulation happens, and you have to superimpose that time with the coital frequency so that there is a very high chance of you getting pregnant on your own. Why menstrual history is important? Because by history itself, there are certain things which we can think about or guess. Example, PCOS woman has a typical cycle pattern, like they are anovulatory cycles. Cycles are not at all regular, getting menstruation once in 1.5 months or more than that. And if she starts bleeding, it does not stop, like menorrhagic kind of cycles. More than that, they are painless cycles. This is PCOS. Coming to endometriosis, they may have little premenstrual spotting, but the premenstrual pain is too much. They get premenstrual pelvic congestion, pelvic pain, dyschezia. These are all unbearable problems that happen during menstruation. That is a typical history of endometriosis. Equally important is adenomyosis, where the woman has severe pain. She's scared when the days of her menstruation are coming near. She's so scared, especially the women who are in their professional field. It is extremely difficult to manage outside work as well as these menstrual problems. The fibroid has a typical history of either dysmenorrhea or menorrhagia. Polyp can cause intermenstrual bleeding if it is inside the uterus, or if it has come out of the uterus, hanging or peeping out of the cervix. It may cause coital spottings, intermenstrual or coital spottings. So the diet, vices, and sleep habits equally important. Diet, carbohydrate diet is not good because she has to take care of her obesity, truncal obesity, BMI, etc. Vices, what kind of vices? Tobacco chewing. Don't be surprised about this. Women nowadays smoking cigarettes or any other kind of vices like alcohol consumption, etc. Sleep habits are equally important. History of taking drugs, maybe narcotic drugs or innocuous drugs, if you think, like OCPs, woman may be silently taking. The scenario may be such that her doctor might have prescribed when she had gone for menorrhagia or irregular menstruation, DUB kind of cycles in the premarital life, and that time her doctor might have prescribed her OCP to regularize the cycle, and this poor girl, without having any knowledge of that, may continue taking these drugs because she was quite happy with this drug. Her dysmenorrhea had come down, her menorrhagia had come down, and her menstruation was on the dot. So she might have been taking these drugs without knowing that these are contraceptives also. Previous history of abdominopelvic surgery, very, very important, especially the surgery around the appendix, surgery around the fallopian tubes may damage the tubo-ovarian relation. Even surgeries like surgery on endometriosis, some geopardic surgery on the ovaries like the removal of the ovarian cortex, or the uterine surgeries like curettage, maybe a gynec curettage like DNC, or the obstetric curettage like the check curettage post-abortion, etc., may cause the endometrial problems, like endometrium may go bald or may be avascular. History of galactoria, thyroid disorders, hirsutism, all are important. All my slides are just giving the bird's eye view. I'm not going to detail because each word we can speak about hours together on each topic. This is just a concised matter. Now, what about the physical examination? Truncal obesity. Obesity is increasing nowadays by leaps and bounds, as all of you know. Blame your diet, blame your exercise, blame your no sleep, whatever, but the truncal obesity, especially in women, is just increasing, and that has inverse relationship with fertility. More the obesity, less the fertility. I need not say again on the body weight or the body mass index. Thyroid and galactoria we should not neglect. Examine the woman for the breast secretion. Ferriman Galvez scoring, very, very important to put where her hirsutism is. So modified Ferriman Galvez score cut off more than 4 or 6 indicates hirsutism. Androgen excess, most of the times because of the PCOS. If PCOS is ruled out, other causes of androgen excess have to be ruled out, like Cushing's. Abdominal open or the lapsed scars. Lapsed scars may be when we put a 3 mm scope. We may not even be able to make out the lapsed scars, but very, very important, because the endometriotic surgery or the dermoid surgery on the ovary, even appendix, might have been performed through laparoscopy. Abdominal mass, very, very important to check. Lower abdominal tenderness, you may find out so many things. You may come to conclusions about so many diseases there. Coming to the proper gynec examination, urethritis, urinary tract infection, and sexually transmitted disease may indicate some kind of pelvic infection and they can cause tubal block or peritubal adhesions, which have direct bearing on women not able to get pregnant. Evaluate the vaginal discharge, especially the vaginal discharge like trichomoniasis, candidiasis, more than anything, bacterial vaginosis. Bacterial vaginosis is becoming popular day by day. It's becoming the buzzword in IVF specialists, where we say that bacterial vaginosis alters the vaginal and the endometrial microbiome environment, and thus can cause infertility. So one has to examine, rule out, or either treat the bacterial vaginosis with simple metronidazole. Per speculum examination is equally important. Check whether hymen is intact. It does happen. You may be surprised when I say this, but many, many patients have come to us with this. We have examined after history taking that the hymen was quite intact, and once you break that, then you will know that she will conceive on her own. Next 6 months, you give her enough chance to conceive on her own at home. Need not do anything extra. Let her try during the ovulation period. She will come back with telling you, doctor, I conceived on my own in next 6 months. All the problem was like the mechanical barrier, and that was intact hymen. Check for the polyp. I have already told. The ectropion of the cervix can cause increased mucus discharge. Sperms may get clogged in that and may not be able to have the forward motion, and ectropion can cause lot of other problems which are related to infertility. Erosion of the cervix, again, the pap test, very, very important, and make sure that the pap test is normal, because sometimes even the atypical changes in the cervix are not right, and you continue your treatment giving hormones, and later you come to know that woman had cancer cervix and take her for radiation, and it's all mess. Assess the cervical motion, very, very important. Why should I check the cervical motion? Tenderness and the mobility, because the cervical motion tenderness tenderness, it indicates that the woman either has adenomyosis or endometriosis most of the times. It may be a frozen pelvis, the parametrium may be fixed, the pouch of Douglas may be full of endometriotic nodules, and because of all this, the mobility and the motion is restricted. The per vaginal examination, what are the things we are supposed to check for? The size of the uterus. Is the size normal? In adenomyosis, even the size increases to 14 weeks. Fibroid gives irregular enlargement or the bossy the growth on the uterus. The direction of the endometrial cavity. Look at this. What I want to say here is the direction of the uterine cavity is very, very important, because when you are doing intrauterine insemination, that is not the time where you have to be struggling. You may think that the uterus is anteverted and you put your IUI cannula, it just hits the cervix, there is a bleeding at the tip of the IUI cannula, and the presence of blood in the tip of the IUI cannula will reduce the chances of pregnancy to a much, much greater extent. So it should be a smooth transfer of the sperm, smooth deposition of the sperm inside the uterine cavity, and for that you should really follow the uterine direction. I mean to say the direction of the endometrium, the tenderness of the uterus and the cervix, the shape of the uterus. It's a uniform enlargement or it's a non-uniform kind, like a fibroid, the mobility, the irregularity, adnexal tenderness. I need not reiterate anymore. I have told any number of times so far. What are the common pathologies ultimately? What are the things you should think of? One, DUB. The history itself does tell us many times, because the cycles are anovulatory and the woman is not able to conceive. The PCOS, the polycystic ovarian syndrome with an androgen excess, pelvic inflammatory disease may cause hydrosalpinx, the endothelial damage, the mesothelial damage, the ciliary motility may be changed, or as I have already told, the tubo-ovarian relation may be altered, the fimbrium may be fused, and the fimbria fail to pick or suck the egg that is ruptured. The fibroid uterus depends upon where the fibroid is, subserosal, intramyometrial, or whether it is a submucous fibroid where there is indentation of the endometrial cavity, the blood supply to the endometrial cavity is altered, the woman may have intermenstrual spotting, and so many things can happen. The endometriosis, I have already told, it's really an enemy of pregnancy, and equally bad is adenomyosis. Post-operative adhesions, whatever was the surgery in the pelvis, and the most commonly ignored or the forgotten thing is the pelvic tuberculosis. The fallopian tube, the endometrium are the main two organs that are targeted in genital tuberculosis, and the chances of pregnancy is just drops, it just nosedives in the presence of pelvic tuberculosis, because it damages, and the damage is irreversible. So this is just a slide putting all things together. Ovary, what are the problems that can be there? The cyst formation in the ovary, or dysfunction, or you can call it as a anovulation in the ovary. The fallopian tubes or the salpinx, PID can cause block or maybe unhealthy tubes like hydrosalpinx or the hose pipe kind in tuberculosis. In uterus, it may be the myoma, or what we call as a fibroid, or the leiomyoma, endometriosis, adenomyosis, fusion anomalies. Okay, what happens in fusion anomaly? It may be the complete failure of fusion like uterus didelphys, or maybe a simple subtle problems like the septum, subseptate uterus, etc. And if you cut the septum, what we call as a septoplasty, then the chances of woman getting pregnant on her own is much, much more. Probably I can put it as around 70 to 80% chance of getting pregnant post septoplasty within 6 months. The spontaneous pregnancy chances are that high. So the chronic endometritis, Asherman's, polyp, and tuberculosis cannot be forgotten. The HPO axis, that is hypothalamo pituitary ovarian axis, these are all the hormonal problems, different kinds of ovulation failure. I'm going to touch upon this in my future slides. The endocrine problems like the hormonal disturbances like PCOS, DUB, one should not ignore checking for thyroid, Cushing's, and prolactin. Prolactin, say up to 20 to 30 is quite okay. More than 40, that means then you have to go for higher kind of investigations. The tract, that is the uterine, cervical and the vaginal tract. The congenital anomaly is the fusion anomaly of the uterus, even vagina, vaginal agenesis, Rokitansky-Meyer syndrome, where the uterus is a very small infantile or hypoplastic uterus with a well-formed ovaries and the adnexa, imperforate hymen, for whatever reason it is, there is non-consummation of marriage. Coming to the peritoneal factors like the chronic PID, maybe because of even chlamydia sometimes, frozen pelvis, endometriosis, tuberculosis and whatnot. Okay, the history is over. Clinical examination of the woman is over. Even pelvic examination I have done. Now I have come to the investigation. Now, what are all the investigations I should do? I should do such investigations which are, because this is a very first stage she has come to me, she has not done many kind of investigation, she has not undergone lot of treatment, she is in the very beginning, the first block. So what are the things? The investigation should be least invasive, cost effective, easily available. It should be such an investigation where I should be able to do in a periphery like a primary health center also. More than anything, talking from the patient's perspective, it is less painful. You would have observed any patient ask, the first thing is, does this procedure cause pain, doctor? So it should be less painful, couple and operator friendly. In the sense, it should not have very high-fi investigation where it is very difficult for the patient to understand, and very difficult for the doctor or whoever is the operator, very difficult to perform. No, it should be couple and operator friendly. It should provide good information about the case. Now, I just want to say here to make you understand more about this fact, say our regular, very friendly HSG, that's a hysterosalpingography. It is least invasive. We don't do anything there. We don't open anything there. It's quite cost effective because any outpatient will be, any small center also will be able to do this procedure. It's easily done, does not need much of expertise to do this procedure, and it hardly causes pain to the patient. More than anything, the ice on the cake is, it gives lot of information to us. We don't have to do, in the very beginning when the patient walks in, we don't have to do a hysteroscopy. We don't have to do big hi-fi investigation to this woman, because this, when I put the speculum, I know that the hymen is not imperforate. I know that the vaginal canal is normal. I have checked the cervix. I have gone beyond and pushed the dye. I know how the endometrial cavity is, how roomy it is. Is there any polyp? Is there any submucous fibroid that is indenting on the endometrial cavity? Are there corneal blocks? And does the dye flow easily through the fallopian tubes and get spilled out of the fimbria, and thus the peritoneal spillage, etc., tells me many things. It gives me lot of information that it replaces many other investigations. At the same time, if you do a postcoital test, now nobody does, it's an obsolete test rather. The postcoital test, say probably around 25 years when we were PGs, we were doing this postcoital test, but it's not popular. It has taken backseat now because it may be least invasive, it may be cost effective and of course less painful, but it does not give me any information. Rather, it hardly gives me any information. So we are not using that test now. There are so many other tests which we don't do now, and I'll tell you later. Okay, now I'm not telling about all the investigations in detail. These are just few investigations I have put here. The hematological investigation, serum FSH, LH, TSH, anti-mullerian hormone, prolactin, CBC, ESR, and glucose tolerance test. These are the hematological investigation. Especially the FSH, LH have to be done on day 2 because that day the ovaries will be sleeping. That is the day when the ovaries are not stimulated. That is the day when the follicles have not erupted, and so we get a basic uniform value. It's a basic value of the FSH and LH, and that is day 2. That's what we want. So we do these two tests on day 2 only. The TSH, AMH, prolactin, etc. can be done any time of the cycle, and that is the advantage of these kind of tests. I'm not going to talk in detail about all the different values except few of them. Coming to the radiological investigation, 2D or the 3D, three-dimensional transvaginal scan, most of the times 2D suffices, because we will come to know about the uterus and all the details of the uterus. We come to know, check about the hydrosalpinx, we come to know what is the AFC, so many things. The Doppler of the uterus, Doppler of the ovary, of course, very, very important, that improves our success rate. The hysterosalpingography, very important. I have just put the important investigations only here. Sonosalpingography, many of us do the sonosalpingography, push the saline or sterile water inside the uterine cavity and check the uterus and the fallopian tubes at the same time, and know whether it is with the scan machine, and see whether there is any fibroid or anything inside the uterine cavity and turbulence in the fallopian tubes. Most of the times the MRI is not done, not so popular among us, because most of the times we come to know either by 2D, HSG, SSG, etc. Suppose any of the tests are not able to part with information, then only is MRI remembered. The MRI is a investigation, probably when you're 2D or 3D, especially, are not able to give you much of information. Especially in case of uterine anomalies, we are happy with 3D because it gives much more information. It contributes a lot there. Laparohysteroscopy, yes, of course, it is one of the very important investigations which is needed sometimes after the above investigations. Okay. Now, I was telling about the FSH, LH, etc. These are the hormones on day 2. These are the hormones which have to be done on day 2 only. What? FSH, LH, estradiol and progesterone. Here, remember the rule of 5. Please concentrate on this slide. What I am saying, rule of 5 is FSH has to be less than 5 milli-international units per ml. This is on day 2 I am talking about. LH should be 5 or less. Again, estradiol should not cross 50. Progesterone should be around 0.5 per ml nanogram, and the endometrium should not cross. Since this is not a blood test, I have not put the endometrium there. When I put my transvaginal scope, the probe, the endometrium should not cross more than 5 mm thickness. So it should be a shed endometrium. Again, the uterus should be in a resting phase, or what I can say is not a stimulated kind of uterus and ovaries, and that's why we are happy with all these investigations being carried on day 2. Okay, now what are the other investigations? Thyroid stimulating hormone should not cross the 3.5 when they are intending to get pregnant, or even in first trimester of pregnancy. Probably we are little more lenient once she crosses say around 12 weeks of pregnancy. Prolactin should not cross 20 nanograms per ml, maximum 30. Anti-Mullerian hormone, or also called as Mullerian inhibiting hormone, should not, this is the normal bracket, normal fertility range, less than 0.5. Again, there are many schools of thought which say that less than 1 is not right, and certain say that less than 0.5 is not right, etc. So less than 0.5, the woman is less fertile, or what we call as a POR, or poor ovarian reserve, or DOR, so diminished ovarian reserve. Okay, look at the other end of the spectrum. When it is more than 3.5, the woman is more fertile. More than 4 nanogram per ml says that the woman may be suffering from polycystic ovary. Why am I stressing on the AMH value here? Because lower AMH value, I am not much worried, because I will second my thoughts by checking her antral follicle count. I will substantiate, or I will find out where her fertility stands by doing another aided investigation, that's a transvaginal scan, which tells me about the AFC. But the higher end of that, that is 4 nanogram per ml and beyond, is important, because the possibility of OHS is much more in these women, even with smaller doses of gonadotrophins. So the tubal function, as I have already reiterated, but Once the HSG is done and it says some problem there, like it may be a spasm in the cornua, whatever, it says that there is a tubal block, I should confirm after diagnostic histolaparoscopy. I should not agree and subject her directly to IVF just because the HSG said that there are tubal block. Let me confirm by using the dye test or pushing the methylene blue dye, checking through the femoral end of the fallopian tube in laparoscopy. Meanwhile, do an office hysteroscopy and let me confirm whether she has tubal block. Because even one tube patent, one healthy tube will change her treatment pattern. The route will change. If bilaterally blocked tubes, both tubes are blocked on DHL, it is confirmed on DHL, or the diseased tubes like tubes which are not nice, dilated, floppy tubes like hydrosalpinx, endometriosis, tuberculosis, etc. I am not happy. I have seen with my eyes that her tubes are not fine during DHL. So let me subject her to further treatment or a higher end treatment like assisted reproductive technology treatment. Now look at this. This is just a very simple investigation. You will learn lot many things here. Look at that. This is a hysterosalpingography where the uterine cavity is quite normal, quite fine, like a pyriform shape. The fallopian tube's course is quite normal. The tubes are not dilated and the dye is spilling out there from the femoral end. Compare that with the second one. Where is the tubal course? I can't see the tube there, and that too bilaterally. I can't see the tube. Is this a cornual block? Maybe yes. Is this a spasm of the fallopian tube? Maybe yes. These are the cases where we have to subject them for diagnostic histolaparoscopy, because here it looks almost like the cornual block, maybe spasm also of the fallopian tube at the osteal level. Look at this. This is the case which is straightforward. I have to subject her to the ART or IVF, assisted reproductive technology. IUI is absolutely useless. It is just time and money wasting technique because her tubes are so circulated. Look at those fallopian tubes. They are so circulated and any person can say that this is nothing but hydrosalpinx. So these are the functionless tubes and they are going to cause lot of deleterious problems. So please subject her to ART and nothing but ART. So the tubal patency test, the first one in the line is hysterosalpingography. Next is sonosalpingography, which I have already mentioned. I have even mentioned about the laparoscopy and the methylene blue dye being pushed to rule out the peritoneal factor. Also, it helps. The hysteroscopic evaluation also is equally important. It's not a big thing. Patient need not be admitted in the hospital. No anesthesia. We just do with the 3 mm scope, and that does not cause pain. You don't have to dilate the cervix. Just put the scope, check the inside of the uterine cavity, and the scope is out. But you get lot of information there about the endometrial cavity, whether there is any polyp, what was the vascularity of the endometrium, where the ostia open, and what not. Coming to the uterine investigation, again HSG is very important. I have already mentioned that it shows the presence of polyp. Look at the polyp there. Look at the fibroid in 3D there. So all these things we come to know with the HSG. These are the aided investigations. These are not the HSG pictures. I'm just saying that HSG tells these also. The TVS 2D and 3D, the MRI, the sonosalpingography, Doppler, diagnostic hysterolaparoscopy. So these are all the investigations that are necessary, or one of these tests can be done for the uterine evaluation. None of these pictures are of hysteroscopy. This is just of the ultrasound pictures. Now, so what are the things we are going to do on the uterus when we know that this is the culprit, the uterus is the culprit? So the fertility enhancing operations can be done either hysteroscopically or laparoscopically depending upon the situation, which may be a simple septoplasty where we just cut the septum and separate. There is no loss of tissue. We are not going to remove the septum. We are just going to cut the septum. The polypectomy is just the removal with using the polypectomy forceps, myomectomy, adhesiolysis, tubal cannulation. This is a very simple procedure. You have to just cannulate the tube through the ostial end, and to your pleasant surprise, you will see that the dye just spills on either side when you do other investigations like combining with the laparoscopy. So the lateral metroplasty, say probably in unicornuate uterus, they were doing much before in the previous era, but it is not a very popular treatment nowadays in fertility enhancing. Laparoscopy, other treatment like myomectomy, adhesive the surgeries on the ovary like removal of the dermoid, endometriotic surgery, and so many kind of fertility enhancing operations. So this is just the hysteroscopic view of all different situations, all put in one slide. Look at that. That's quite a normal, roomy uterine cavity, and embryo can happily sit there. The fibroid is such a big growth there which does not allow the embryo to sit. The polyp also can cause problems. Usually the polyps are pedunculated and they are less vascular. They are not more than 1 centimeter. Usually can be easily removed with the polyp forceps. Asherman syndrome is quite tough, very difficult. Post-operatively, the woman has to be on estrogen. The roomy cavity has to be created. The septum resection is quite rewarding and quite easy. Just look at the shrunken small uterine cavity, maybe because of the tuberculosis. So this is laparoscopy or pelviscopy, which shows multiple uterine fibroids there. Now, what are the principles of fertility enhancing surgery? So any surgery, one should follow these kind of norms, or the discipline should be followed, all the more when it is a fertility enhancing surgery. And they are minimal tissue trauma, especially when you're operating on the ovary like desiccation and injury. You are supposed to use only the bipolar or higher end desiccation systems, that's the cautery systems, not the monopolar cautery. Maximum hemostasis, very, very important. Restoring anatomy. Example, the tubo-ovarian relation has to be maintained at the end of the surgery. Your surgery should be done in such a way that the anatomy is restored. Tissue approximation, say in case of a huge myoma, tissue approximation, especially when you have entered into the endometrial cavity, is very, very important. And you have to avoid collection in the dead space, because the scar will be at stake, or scar will be having problem in future pregnancy, especially in advanced pregnancy. So tissue approximation is very, very important. And the other principles of lap surgery, like surgery on endometrioma, where you have to use the bipolar cautery and need not coagulate each and every point, pressure, intercede use, so many things. Endometriosis, myomectomy, laparoscopic ovarian drilling, tubal pregnancy, that is, it's a tubal abortion, or you may do remove the pregnancy by milking, so the tubal reconstruction. So there are many kinds of surgeries where we have to take care of the respect the target organ when we are operating, keeping fertility in our mind. The following principles for the hysteroscopic surgery. The previous line was on lap surgery. Now I'm talking about the hysteroscopic surgery, like the septal resection, submucous myoma, very, very important. The post-adhesivolysis estrogen supplementation, whether it's a surgery like the septoplasty or submucous myoma or lateral metroplasty, is very, very important. Probably around 3 months of 2 milligram twice a day of estrogen supplementation is quite important, so that the healthy endometrium grows, which will be quite vascular. So these are the different myomas there, and this is the hysteroscopic way of tackling the myomas there. Now, about myoma, the fertility perspective would be, you have to know the size of the myoma, number and site, where the myoma is. Is it impinging on the endometrial cavity, or it is happily dangling around in the subserosal space? Intervention that is needed is if the fibroids are symptomatic, causing lot of symptoms to the woman. If the size of the fibroid is more than 4 centimeter, if they are submucous, because the endometrial blood supply will be hampered and the distorting cavity cavity because the embryo cannot sit there, and there is a lot of inflammation because of the endometrial irritation. Whether the fibroids are multiple, if the fibroids are multiple, 3-4 centimeter fibroids, there are around 8 to 10 occupying the whole of the uterine corpus and distorting the cavity. These fibroids have to be removed off. We have to get rid of these fibroids first. Medical treatment has absolutely no role in the fertility perspective. If the cavity is affected, these kind of fibroids have no business to sit there and they have to go. The counseling is very, very important pre-operatively and post-operatively when we have removed these myomas, because the woman should follow 1 year of contraception, because the scar has to gain its strength not only for the beginning of pregnancy till full term. The scar of the uterus should maintain its strength, so contraception is very, very necessary till it gets its strength. So you have to counsel that the scar rupture may happen if she conceives early. If the closure was not proper, there is a chance of scar rupture. And another important thing you have to counsel her is that the chance of recurrence of the myoma is much, much more. So the woman should know this fact, because otherwise later on she may come and ask us, doctor, you said there were 2 myomas, you said you have removed those myomas, now I have come back to you at the end of 6 months with 3 myomas. Have you not operated on me at all? So it's very, very important for us to that myomas are known to come back. They are just round the corner. The chances of recurrence, especially when they were very small, inconspicuous seedling fibroids, there is a very high chance of them coming back as far as the uterus is there. The endometriosis fertility perspective of endometriosis is laparoscopy is the golden standard for the diagnosis. So even if it is 1 and 2 grade endometriosis, because early endometriosis may be like salt and pepper pattern, you may not be able to do by understand or diagnose by scan, because they are so small. If you are seeing with your own eye, you will be able to know, because they are not space occupying. So laparoscopy is the gold standard not only for the diagnosis, even to touch upon those spray kind of pepper appearance, the touch upon and don't allow that endometriosis to grow there. So you have to cauterize those endometriotic spots. First of all, for the diagnosis of the endometriosis, laparoscopy is the gold standard. CA125 has some role in the diagnosis and treatment. Treatment is more important regarding CA125, because you will know the prognosis of the case with CA125, though it is not an important or a gold standard in the investigation of diagnosis of endometriosis. Transvaginal scan will tell us if it is either a space occupying like ovarian endometrioma, where you typically see that ground glass appearance of the ovarian endometrioma, or if the endometriosis nodules are there in the pouch of Douglas, etc. Otherwise, TVS, early endometriosis, TVS may not throw much light. The medical treatment, less than 4 centimeter ovarian endometrioma, the medical treatment is the treatment of choice, what we call as a sandwich therapy. That is the surgical therapy, that is a surgical removal, that is either cauterization, stripping, removal, drainage, whatever you call, different kinds of surgical therapy put in between the 2 medical therapy. That is, first is medical therapy, in between is the surgical therapy, and again the medical therapy. This is the kind of treatment one should follow, and surgical therapy should not take the first hand or the upper hand always, because it is going to remove, when we remove the cortex of the ovary, lot of follicles, we know that a lot of follicles go when we strip the cortex, and these are the follicles which we need, the much sought after follicles. So the counseling is again necessary here. And what are you going to counsel on? You are going to tell the woman that your AMH should be done before I subject you to the endometriosis surgery. This is very, very important, and this may have medical legal consequence also, because if you have not done the AMH, you are straight away subjected her to surgery, especially the ovarian surgery or the use of cautery, and later she comes to know that her AMH was 0.5 or less than that, she may say that it might have happened because of the surgery itself. So pre-op AMH is very, very important to tell her, look, this is your fertility, this is where you stand. So that's very important. You also have to counsel her that endometriosis is a locally recurring disease, it's a chronic disease, and it creates lot of problem in the fertility treatment. It comes in the way of treatment many times. So it's a very hostile thing that happens there. These are the things which are very necessary when you counsel that woman. Coming to the ovary, I have spoken already about the salpinx. I have explained about the endometriosis. I have already explained about the uterus. Let me talk a little bit on the ovaries. So the ovarian disturbance, all of you know the WHO classification of the ovarian ovulatory disturbance. Let me not describe much on this. 1, 2, 3, 4. Our PCOS, the very, very common disease what we see nowadays, comes in group 2, that is the normogonadotropic normoestrogenic ovarian failure. Coming to the ovulation defect, out of this, the same previous slide, I'm just telling you here that most of the people fall in this. As I have already told, that's a type 2 PCOS, where previously we were saying that it is 2:1 ratio. What? FSH to LH. Need not be so. Most of the times the FSH may be marginally raised and LH may be little more raised, or it may not be like a ratio of 1:2. And the estrogen is most of the times normal or slightly elevated. Type 1 is a hypogonadotropic hypogonadism. We are very happy to treat these kind of patients because it gives rewarding results. Like as we do the septoplasty and the woman comes back in 6 months with pregnancy. Similarly, this is also quite rewarding kind of disease because the FSH is low, LH is low, E2 is low. When you supplement them with gonadotrophins which contain both FSH and LH, maybe like HMG, the woman gives a lot of throws a lot of follicles there. The follicle just develop and she conceives on her own most of the times, provided you've taken care of her FSH, LH by supplementing. These are the tests I was telling that they are out of vogue. What are they? The BBT, that's a basal body temperature. We hardly do nowadays. The present generation PGs don't even know probably what is BBT. The serum progesterone level more than 3 nanogram per ml on day 21 is not done nowadays. It's because it's not much reliable. The Novak's criteria, whatever we were saying with the histopathological examination of the endometrial dating, who does now? No, it's almost obsolete. Postcoital test, LH ovulation prediction kit is not done so often because all these have been replaced by sonography. Patient at home, the woman at home can check when she is nearing ovulation with using the dipstick, the urine dipstick regarding the ovulation by using LH kit. Now, monitoring the ovarian stimulation, how do you monitor? It's only by transvaginal ultrasound and nothing else. So you check for the number and size of the follicles, what we call as antral follicle count. You also don't forget to check the pattern and thickness of the endometrium. Not only the details of the uterus, probably you would have made a rough estimation or understood about the details of the uterus in your previous month scan. But this month, when she comes to the day 2, it's your duty to check the number and size of the antral follicle count. And not only that, don't forget or ignore the endometrium, and the endometrial thickness should be less than 5 millimeter, which goes on increasing. And during or around ovulation, the size of the endometrium would be around, say, around 8 to 10 mm with the beautiful trilaminar layer there. Look at the trilaminar layer there. This is around the periovulatory period. Now, the estrogen blood level, some people do, some do not do because it may not be necessary. I usually do not do because my sonography tells me most of the things, and the estrogen is almost replaced the very beginning once, and make sure that it is less than 50, and that should suffice. Every time the estrogen level is not so necessary. Now, coming to the, when you do a scan, what are that's only the transvaginal scan and nothing else, as I've already told. What are the things you're going to check? ovary, you check about the size and number of the ovulate developing follicles, progressive follicular growth. The follicle size should come to more than 17 to 18 millimeter just before rupture. Then it should suddenly collapse and the margins become clear, and the follicular fluid goes into the pouch of Douglas, and you see some thin film of fluid in the pouch of Douglas. The Doppler is a very important investigation. The perifollicular flow encourages us and it tells us that the follicle has come out quite good and it's a quality follicle. What are the things you are checking in endometrium? As I have already told, the trilaminar appearance, growth up to 8 millimeter around the periovulatory period. Again, the endometrial Doppler, the subendometrial Doppler, and you will know what is the resistance index, etc., etc. So coming to the, I'm in the last few slides. Please excuse me, and I sought after. I expect your cooperation there. So the analysis of the ovarian reserve, define the goal of the ovarian stimulation, select the correct protocol. These three are very, very important. You should know the ovarian reserve, whether the woman is which category she belongs to. Is she a woman of poor ovarian reserve, normal responder, or a high responder, where the dose of gonadotrophins or even oral ovulogens will be tailor-made according to her ovarian reserve. Select the correct stimulation protocol. What kind of treatment are you going to give her? First of all, is it IUI or you are subjecting her to ART? If it is ART, what is the dose of the gonadotrophins you are giving? So many things. Is it the antac protocol, long protocol, so many things. Anyway, so before starting the ovulation stimulation, that's in the previous month itself, all these things should be made note of. It's a single follicle development that is expected in natural cycles. Of course, yes, it is the one follicle that comes every cycle in alternate ovary, but in ART cycles, that is not enough for us. We are very greedy and we want multiple follicle development. The more number of follicles, more number of M2 oocytes, we are happy because the success of pregnancy is, the chance of pregnancy is much more there. Now, what is AMH and what is AFC? Anti-Mullerian hormone is the hormone that is secreted by all tiny granulosa cells of the growing follicles. They haven't grown. They are the all small follicles of 2 to 8 millimeter, less than a centimeter size follicles. And mind you here that it is a quantity that is important because it is the summation of the performance of all the follicles and not in individual follicle. So it just gives the quantity of the follicular performance, and it does not tell me quality of each follicle. It's a costly test. I have to depend on somebody for this test, and so repeating the test may be difficult, and there are so many methods in this test, and it's a very intricate one. The value, coming to the value, more than 3 is PCOS, the woman is more fertile. Less than 3, more than 0.5 is a normal range, and less than 0.5 is premature ovarian failure. Coming to the antral follicle count. In antral follicle count, it is the woman friendly, the patient friendly rather, and the doctor friendly, because you have invested in the scan machine in the very beginning, and after that it does not cost much because you can do any number of scans. It is your observation, you are making the diagnosis, unlike AMH where you have to depend on somebody else to give you the value and you have to believe his value. Whereas in AFC, it's the day 2 scan that tells us the number of follicles. I know how many follicles have come up, which is not the fact that is revealed when I check the AMH. It predicts, the AFC predicts the oocytes at the egg pickup. How many eggs I'm going to get? I have to tell my embryologist to make the plates. So he should know how many eggs I have picked. And the dose of gonadotrophin that is given, it is easily accessible. Transvaginal scan, anybody can do. Check for the ovaries bilaterally, and it is totally painless. It is cheap and can be repeated many times. There are no intricacies. The gynecologist is the operator, and she or he is going to make the decision, not depend on somebody else. And the normal value is always, it is 2 ovaries put together. 5 to 15 is normal. More than 20 is PCOS, premature ovarian failure, or diminished ovarian reserve is less than 4 to 5. So coming to the types of ovulation, it's if it is just the correction, it's a dysovulation or anovulation. These ovulation correction is enough, like in DUB cases. But when it comes to IUI, you need super ovulation, you need 3x or around 2 to 3x, whereas in ART, it is a controlled ovarian hyperstimulation. These are the drugs that are used. Clomiphene and tamoxifen are the oral ovulogents, and an aromatase inhibitor is letrozole, gaining fame, used right and left by many of us. Gonadotrophins are the HMG, and recombinant FSH is the gonadotrophins, which are usually used in ART cycles. What are the different kinds of treatment in PCOS? The lifestyle changes, that's the diet and exercise, ovulation induction. Metformin is gaining popularity, used by many of us in treatment of PCOS to maintain the hormonal milieu. Laparoscopic ovarian surgery, not so famous, and in vitro fertilization may be needed in extreme cases where IUI many number of times has not helped her. The clomiphene citrate. Clomiphene is a partially, why I have just put the slide is because a very, very famous drug used by many of the gynecologists, even by other family physicians, used many number of times. So little thought on clomiphene citrate. It's just the input would be clomiphene is a partially selective estrogen receptor modulator. It induces a change in the gonadotropin pulse frequency. It acts in the positive feedback arm of the HPO axis. It increases the FSH level. Therefore, it promotes the follicular development. Used for ovulation since long time, probably before I was born. For 5 days is the standard duration of treatment, starting on day 2, and you can go up to 150 milligrams per day, starting from 50 milligrams. The chance of ovarian hyperstimulation is much less. Obese PCOS women tend to have clomiphene resistance. Let me not talk about what is clomiphene resistance, what is clomiphene failure, etc., because time is really running out. This is another important slide I would like to mention about why I favor or I'm in favor of letrozole over clomiphene citrate. Mode of action of clomiphene is selective estrogen receptor modulator, whereas letrozole is an aromatase inhibitor. Half-life of CC is much more, sometimes even up to 5 to 7 days, but it's very short acting in case of letrozole, that is less than 2 days. Rather 2.5 days, it stops acting. Anti-estrogenic effect is much more in clomiphene citrate and less pronounced in case of letrozole, in the form that is clomiphene, though it gives good follicles, more follicles, the endometrium is not so supporting, and endometrium is very thin, and it alters the cervical mucus, that is, it is not good estrogenic cervical mucus. Whereas letrozole gives a nice fluffy trilaminar endometrium, and even the cervical mucus is very thin and thready cervical mucus. Uterine blood flow is decreased because it's an anti-estrogenic action on the uterus, but it is increased in case of letrozole. So because of this, summation effect would be, though woman gets pregnant, the miscarriage may be much higher in case of clomiphene, unlike letrozole. The OHS, that's ovarian hyperstimulation risk, is much more in case of clomiphene and low in case of letrozole. So multiple pregnancy, because it's a long acting, chances are much more in case of clomiphene and less in case of letrozole. So letrozole is the drug that is much superior to clomiphene according to so many studies, considering the live birth and the pregnancy rates, both in patients with PCOS, and the dose is usually 2.5 milligram OD to 2.5 milligram BD from day 3 to next total 5 days. Letrozole use does not increase the risk of congenital anomalies in the newborn. This was a stumble block on letrozole, and for a long time the letrozole was not released into market because of this reason, but it has cleared all these doubts in our mind, and it has come out in a very great scale. So the general advice to the couple would be, it's just a summary of the slide, is the sexual contact to cover the ovulation period, maintain your BMI, that is weight has to be in the optimum range of 19 to 24, that is the BMI I'm talking about. Stop all vices or limit your vices. Lifestyle recommendations, it's a diet and exercise to maintain a healthy BMI is very important. Preconceptional counseling and adding folic acid as the pre-counseling medication is quite important. take care of the occupational hazards and stay away from that. Educate yourself, especially during the corona times when you are at home. If you have lot of time in hand, why can't you go through the YouTubes or so many other information in Google and find out about the fertility, infertility, what is ART, what are the drugs, how to control my weight, and so many things. The stress management need not be stressed anymore. It is very, very important. So the management option would be appropriate counseling, fertile window covering the ovulation, ensure that consummation of marriage has happened. May be surprising or may look too preliminary to you, but very, very important. Monitoring follicular genesis to know how many follicles have come up, when I have to give the injection for rupture, etc. Tubal patency test, ovulation induction with all the different kinds, and fertility enhancing surgeries. These are all the different management options. So the couple should have patience, faith, will, and should have accumulate enough knowledge about their problem, that is the fertility issues. They should have faith in their doctor, and they should have the will and determination to conceive. Cannot leave the or drop the treatment effort in between. Coming to the treating physician, the doctor should have the basic skill of HSG, the office hysteroscopy, or simple tests and the treatment like IUI. They should have the will to make that woman pregnant. That determination is very, very important. And doing all this, patience is equally important. Coming to the second half of my talk, very few slides here, please bear with me. The COVID challenges in infertility practice, the part one of the basic treatment or the approach of the infertile woman is over. This is just about the COVID challenges. No known difference between the clinical manifestations of COVID-19 in pregnant and non-pregnant women. Two arms, that is arm one is pregnant woman, arm two is non-pregnant woman. In both, if the get affected with COVID-19, fortunately there is no change between the two. COVID-19 in pregnancy per se is not going to make much change. In spite of knowing this consolidated fact, all fertility patients considering or planning treatment, even if they do not meet the diagnostic criteria for COVID-19 infection, like RT-PCR was negative, the RAT, that is rapid antigen test, was negative, in spite of all these things, they should avoid becoming pregnant in the COVID time. Probably the statement is bit older because we have come out of the second wave now. Say in May this when we had the COVID wave, probably this slide was more appropriate. So the coronavirus COVID-19, this is the ISHRE statement, that the ISHRE statement on pregnancy and conception is as above. Why ISHRE was saying that the woman should not try to get pregnant? Because to avoid the complications from assisted reproduction treatment, coming to the doctor many times, getting scan done, showing the reports, walking out of the house many times, she may contract infection. To avoid potential SARS-CoV-2 related complication during pregnancy. Suppose with all this treatment she gets pregnant, you really don't know whether that is going to cause complication or to the pregnancy itself. Then third is to mitigate the unknown risk of vertical transmission. In the sense, does it cause problem to the baby? We don't know. We are not sure because this is a new infection. So you really don't know. So make all facts clear, then try to get pregnant. This is what ISHRE was saying. To support the necessary reallocation of healthcare resources, because healthcare resources were very small. We were not having half number of the staff. With less number of staff, if we reallocate them to pregnancy or ART treatment, where do we have the staff to treat the COVID patients? So keeping for both these things, that is COVID treatment and ART treatment, was getting difficult. So the priority was COVID and not pregnancy there. So to observe the current recommendations of social distancing. So in cases of urgent fertility preservation, say like oncology patient, where you can't tell them to wait. The COVID is there since probably past 1.5 years. I can't tell my oncology, that's a cancer suffering woman, that you wait because her oncology treatment should be done on war footing. That is very important for her. So the cryopreservation of gametes, embryos or tissues was very, very important there. So these are the women where in spite of COVID wave, we had to give her the treatment. These are all the general instructions one should follow as a doctor. All of us know that you use PPE kit, then clean all the surfaces, proper disposal of biomedical waste, all that in summary. The telemedicine has come legal now. It's become legal. Doctor has to decide which consultation can be online. All consultation cannot be online. So if I have to see her scan, that is check her AFC, I cannot do it by teleconsultation. It's just common sense. If patient approaches the doctor, it means it's an implied consent. You don't have to take a separate consent for that. Medical legal matters are similar to any face-to-face consultation. So you have spoken to the patient on teleconsultation, but the medical legal problems would stand same to both. So any party can withdraw anytime, the patient party or the doctor party. This is the staff management, again all in summary, that is triaging. The administrators and counselors can sit at home and they can counsel the patient. When we are taking the patient for the procedure, use PPE kits, so many things there. The patient instruction, like again triaging of the patient and then only take them for treatment. Then minimum stay in the clinic. They can consult you online on WhatsApp or email or chat with you and find out about the treatment, what you're going to do, the counseling part, showing you the reports, etc. And the payment should be online payment. Encourage online payment along with digital transaction. This is staff and patient triage. All of us know that when they are in the gray zone, then they subject them for tests. Suppose they are totally asymptomatic, they can be taken for treatment. If the report comes positive for SARS-CoV-19, then even the health staff, that is the hospital staff, that is a paramedical or even patient, cannot proceed and they have to be in quarantine. So the treatment, when you start, it should be from the diagnostic infertility testing. Then after few months, take them for FET and IUI, and more invasive procedures like the pickup, embryo transfer, etc. you can do later. Oocyte retrieval, ovarian stimulation, because they have to come repeatedly. These things can be done, taken in, resumed in phases. So it's a counseling that is very, very important. You also counsel them that anytime we may have to discontinue if the woman turns COVID positive during the treatment. This is very, very important. Otherwise, this may land you in medical legal suit. This is very, very important because patient would have spent some amount of money and she's thinking that she will get pregnant, and suddenly you tell her that you discontinue the treatment if you have not trained her beforehand. That's not right. So it's assumed that sperm, oocytes, and embryos do not have receptors for SARS-CoV-2 and they are unlikely to be infected. That's a very good news for us. More than anything, the zona pellucida is a hard coat around the egg, and that represents a high level of protection for the oocytes and embryos. So these are the patients where we cannot defer the treatment, the infertility treatment, be it a COVID pandemic, second wave or third wave. And who are those? One is the ovulation treatment has already started. They have already in the ovulation fertility journey. The induction has already started. They are in day 7, day 8, and she's on top of that, she's negative. The couple are negative. I have no reason to stop the treatment there. The case of fertility preservation is the second situation where the woman has to be taken for the chemotherapy or radiotherapy on war footing, and no way that cannot be postponed. The woman of premature ovarian reserve is another woman, especially in scenario like pandemic, which sweeps the countries over so many years, where I cannot tell this woman to sit at home with knowing that she's a woman of premature ovarian reserve. So these are the situations where in spite of COVID-19, the woman has to be subjected to treatment. Now this is the slide which says before stimulation for IUI, what are all the COVID precautions one has to take. This is just the ISAR IFS AC recommendation, all in nutshell, all put in one slide. what are all the precautions. I'm not talking about our IVF, ART, further procedures like third party reproduction, embryo transfer, etc. I'm just talking at the IUI level and below that, not more than that. So all units, they have to take care of all these important points. Now, the vertical transmission, is it possible? Neonates delivered by the positive mothers, these are COVID positive mothers, have tested negative for the virus. The neonates have turned negative, whereas the mother was positive. Evidence for intrauterine infection caused by the vertical transmission in late pregnancy is lacking, fortunately. The consequences of infection among women during early pregnancy is unknown. Although the evidence of vertical transmission is still unclear, it may be possible. Last two slides probably. The few reports have suggested vertical transmission, and what did they say? This is the first scene where the infant tested positive, but the test was done at 30 hours of the birth. That is, when the child was 30 hours, that is around 1 day and plus, then the test was done for COVID and the test was positive. So how do I say that it is not the horizontal transmission? It may be quite possible. The horizontal transmission might be possible in this scenario. Look at the second one, is a bit different. Then the doctors became more clever. The newborn was tested positive for the virus as soon as the child was born. Within few minutes, the throat swab was probably taken, and that was tested positive. Here, it is the stronger evidence that may be interpreted as a vertical transmission. That's from the mother to the child. So it's not ruled out yet whether the vertical transmission is possible. So this is the final slide. The good practices for resumption of the reproductive care are so many. That is, you have to be careful at every step regarding discussion, agreement, the staff and patient triage. The whole scenario has changed by 360 degrees, and there are a lot many new things that have emerged we have to take care of and take notice of during the treatment of these women, like appropriate distancing, adjusted work shift of the staff, because you have limited number of staff, the sanitation procedure at every level, I can say, because they have to be followed so strictly. The high-risk patients should not start the treatment until permitted by relevant healthcare professional. Patient must sign and adhere to the code of conduct and agree to discontinue treatment if necessary, as I have already told. Inform patient about the risk and prevention of the viral transmission. Offer the choice of proceeding or postponing treatment. Let them decide either of the two, whether they want to proceed or they want to postpone the treatment, but document the same. Document what patient prefers. Fact about vertical transmission is still not clear. So the time has come to change the current trends regarding the crowd should be minimized, in the sense the hospital staff should be less number around the patient attendance. When they come from home, the patient can come alone or maximum with her husband, mother, one attendant. The number of visitors, if they're admitted, should be restricted. The number of visits to the hospital itself as outpatient should be restricted. The OPD hours should be shrunken. Encourage the healthcare workers and patients to practice preventive medicine. Encourage telemedicine and online payments. What all changes has come? Who has guessed all these things, that these things are going to happen? Okay, anyway, I have come to the end of my slide, and the culminating slide is thanking you all for your patient listening. I know that I have taken enough time of yours and extremely sorry for that, but I could not do anything. I have reduced the slides to very great extent. I was given two vast topics and I had to cover both. So because of that, I had to take this much time. Thank you so much. Thank you all. I stopped my slides, sharing my slides here. Thank you.
Thank you, ma'am. Thank you so much for giving lots of information in less time. And it was very informative topic. Like most of the questions were solved in your presentation. Let me see if we have any queries in the comment section.
Yeah.
So, ma'am, the general question is like that, is there any psychological impact on the patient due to this fertility treatment suspension during COVID-19?
Yeah, if you have not explained to them, yes. See, first is one category of women where they can really wait because say
Yeah.
just 1 year of married life or probably 10 years of married life, the other end of the spectrum. Anyway, she's waited for 10 years. What is going
Yes.
to happen in 6 months, next 3 months? Or 6 months,
Yeah.
or even very early they have come, just 1 year of married life. Even some people do walk in at 6 months of married life. So you can counsel them and tell them to wait for some time. If you have
Yes.
not counseled them properly, then the problem is going to erupt, because you have to tell them that, see, if you become COVID positive, or if your husband becomes COVID positive, that's not right for the baby, and we may have to stop the treatment in between. She might have spent around 8 to 10,000 or something for the investigation, treatment, the
Yes.
gonadotropin injection, etc. And suddenly you tell her one day that I'm going to stop. She will be thinking that she's going to get pregnant, and on top of this, she has spent so much time and money. And if you're going to suddenly tell her, definitely that's not right. You have to tell her right in the beginning. But I have also shown a slide where three situations where you have to continue with the treatment, be it COVID or anything else.
Then one more question is that is it required all the time the COVID screening for the patient who are coming for IVF treatment?
Yes, of course. Even for IUI treatment, when you are subjecting them for any procedure, COVID-19 testing is very much necessary, even if they're asymptomatic. I'm not talking of the OPD patients. I'm talking about those women where you are subjecting them for IUI treatment or IVF treatment, not for the OPD patient. The testing for the COVID-19 is very much necessary. Because if she's negative only, you're taking her for
Yeah.
the treatment.
Okay. And what if the patient is going through all the procedures and suddenly in between the patient gets positive,
Yeah,
COVID positive?
I have shown in the slide.
Yeah.
That is what is the counseling also, that to check her in the beginning. Suppose she's negative, you start the treatment, but in between, suppose she turns out to be positive, say day 10 or day 12, then you have to stop the treatment. She can't continue with the treatment, and the same thing holds good for the husband also. You would have done a semen analysis, he was negative
Yes.
for COVID, but the day of giving sample, he turns out to be positive. You have to turn him down and tell him that you cannot give the sample now because he is COVID positive and you really don't know about the vertical transmission.
Thank you so much, ma'am, for providing all this information and solving our queries. And I also thanks all the participants to listen, Dr. Rekha. We are very pleased to have you on this platform, ma'am, and we will also have more topics with you on Shield Connect. And I also
Okay.
thanks my colleagues from Shield who made this webinar possible today. Thank you so much, ma'am.
Yeah, thank you, Shield Healthcare Pharma. Thank you, sir. And thank you, Nishant, for giving me this opportunity. I know I took long time of yours, and please
No,
excuse
no,
me
no,
for the
that was
same. I hope
it was very
the,
good
the
presentation.
participants could gain some knowledge from this talk.
Yes.
And if that is the thing, I'm very happy. Yeah, thank you so much.
Thank you very much, madam. That was a
Thank you,
wonderful
madam.
talk,
Thank you.
and you covered all the nuances of the topic. And we would like to have you again, you as a speaker in this forum.
Yeah, yeah,
Thank you very
fine.
much.
Yeah, yeah. Thank you so much. Thank you. Thank you, Mr.
Yes.
Sanjay.
Thank you, madam.
Yeah,
Thank you very
yeah.
much. Nice presentation,
Thank
ma'am.
you. Thanks for the opportunity. Thank you. Shall we disperse?
Yes, madam.
Yes, ma'am.
Thank you. Thank you.
Bye.
Bye-bye.